So, good evening and welcome to the Royal College of Surgeons of Edinburgh webinar this evening. Tonight's topic is around virtual consultations, the art of the possible, and we have a stellar panel of great communicators with us today. First up is Claire Morrison, who's the clinical lead for NHS Near Me. And Claire really was the brains behind Near Me, but she was just telling me that actually it was a small group of patients up in the very north of Scotland that chose the name. And I think it's over 16,000 consultations were performed by NHS Near Me last week. So that's an amazing testament to Claire. We're followed by Charlotte Gunner. Charlotte is a urology trainee. What you can't see from her picture is that she's very heavily pregnant, and so if she rushes off, you'll know why. And so Charlotte's going to talk to us about her experience in training medical students in virtual consultations. And then we have Idris Thomas. Idris is a consultant psychiatrist locuming in NHS Lothian at the moment, but has worked up here in the sunny Highlands. He was just bemoaning that actually it's a bit overcast in Edinburgh, where it's a beautiful Highland day today. So, and just to give you a flavour of the different backgrounds that work well with virtual consultations, I've deliberately chosen the worst background, which is a load of books, whereas Dr. Thomas has got the best background in terms of that, not distracting. So without much further ado, we're going to start off with Claire, and she's going to present.
Thanks very much. I shall just share my screen. Thank you. So I'm going to give a bit of an introduction about what Near Me is and what's been happening over the last few months. So in really simple terms, Near Me enables people to have consultations by video using a device, so a smartphone, a tablet, a computer with a webcam, and it's a web-based platform. So patients are sent a link to go to, and then that brings them into a virtual waiting room. So this is the view of the virtual waiting room that a clinician would have, and they would see the names and dates of birth of their patients, and they simply would just click on the patient name that they want to see, and that opens a video consultation. And that consultation looks a bit like this. So you see the person that you're consulting with in large on your screen, and then a little image of you down at the bottom. And the platform has a number of different functions. So it has a chat function, mute mic and disable camera is something we're all getting more and more familiar with. You can share your screen, so you can share, for example, some test results, a scan result and so on. And you can also invite other people into the call. So that can be really useful for multidisciplinary team consultations, inviting an interpreter in, and equally for having another member of the patient's family involved in a consultation. So we've been kind of working on Near Me for a few years, since late 2017, and actually in March things changed dramatically. And that was obviously with the advent of COVID, and suddenly people were interested in virtual consultations in a way that really hadn't been seen before. So we embarked on a 12-week program really to help clinical teams to scale up Near Me, and this is really what we've seen. So prior to February, we were doing around about 300 Near Me consultations across Scotland a week, and last week the figure was 16,741. So it's just been a massive growth across the country, and that growth has been seen in just about every clinical specialty you can think of. So I'm not expecting you to be able to read this, but just to show the breadth of different specialties that are using Near Me across primary care, outpatients, inpatients, and indeed in community services as well. At the end of every consultation, we have a little pop-up survey that comes up, which asks patients a whole lot of questions about their experience. And one of the things we ask people is, would you use Near Me again? And it's an overwhelming proportion of patients who would use Near Me again. And I think that that's really fantastic, especially given that we've maintained, this is just very recent results, and we've maintained that even though we've brought on a whole lot of new people into using the system over the past few months, and patients are still getting a good experience from the service. I never talk about near me without talking about its place, and it's really important to say that near me is a tool, and it's up to clinicians to decide how they want to offer it to patients, and indeed for patients to decide whether or not they wish to have a consultation that way too. So it has a place somewhere between telephone and face-to-face consultations. So there'll be some situations when a phone is absolutely enough, and there'll be some when you really need a face-to-face consultation, perhaps because you need a physical examination. But there's a whole load of consultations in between where a video provides much more enhanced information than a phone call would, and we've a lot of evidence to suggest that patients find it much more reassuring than a phone call. So being able to see their clinician is important to them. So where are we looking at in terms of near me in its future role? So we have a fairly clear rationale for this, that all health and care consultations could be provided by near me whenever it's clinically appropriate. So stressing that that still is an important consideration. And that will enable the health or care professional to be at home or at work, and equally enable the patient or client to be at home, at work, or indeed at school or a local clinic. And there are three reasons for this. The first one is that COVID is going to be with us for some time to come. And so near me still enables patients to be seen with physical distancing in place. Secondly, going back to one of the reasons why we started near me in the first place, it's very much around person-centered care and meeting a demand from patients. So we know that there are patients who find it really difficult to attend face-to-face consultations at clinics, perhaps because of responsibilities they've got at home for childcare, for example. There's a lot of people who aren't allowed time off work to attend appointments, so they end up taking annual leave to attend. And indeed, there's all the barriers around rurality and transport and mobility. So there is a patient demand for this kind of consultation. And thirdly, it's environmental imperatives. And every time someone makes a journey, whether that's in a car, on a bus, on a train, that journey has a carbon footprint. And near me provides a way to try and reduce that carbon footprint. So in terms of setting up near me, this is our three-step approach that we've used over the last 12 weeks. It focuses on three areas: technical setup, service processes, and individual training. In terms of the technical setup, so both patients and clinicians need three things: a reliable internet connection, a device for making a video call, and the Chrome or Safari browser. And in terms of the service processes, I think that this is the most complex area in terms of getting set up. We tend to suggest to people that they think very much about their whole process of how they offer consultations, and think about how near me will be embedded within that. So thinking about things like, what are the criteria for use? How's the appointment booking going to work? How's a patient going to enter the system? So we know if patients are given a link on a piece of paper that they have to type into their device, that can cause mistyping errors and people can end up in the wrong place. So electronically providing links can be really useful for that. Who's going to answer the video call? Is that going to be the clinician straight away, or are you going to have a receptionist? And then the consultation process itself. How does that work when someone's providing a virtual consultation? And finally, follow-up arrangements. So if you're seeing someone remotely and they need a prescription, how are you going to supply that prescription to a patient? So we've got lots of implementation guidance on the tech.scot website, which talks about different areas that near me can be used and things to think about in terms of setting it up. And we also have a patient information website at nearme.scot, and I really encourage people to look at this website. Firstly, it provides the information that patients will see, but also it's got a make a test call function. So if particularly patients who are perhaps less confident about, could I use this kind of technology, they can go on here, make a test call, they get through to a waiting area, so they can see the whole process of what it's like to use near me before their actual appointment. The final part of setting up near me is in terms of individual training, and we have a whole load of resources on the CHIRAS platform which cover technical skills, video consulting skills, and practice processes, and I'm not going to dwell on them because Charlotte's absolutely going to speak about this a bit later. But those of you who were observant at the beginning would have noticed that I called this a 12-week scale-up program, and yet my nice chart has up to week 15. So we have exceeded our initial 12 weeks, and we are now in the what next stage of what to do. So the good news is that growth of near me has continued beyond that kind of initial 12 weeks of support that we've been providing, and we're now looking at what happens next. So First of all, we've developed a national vision for Near Me. So that vision is also available on the tech.scot website. And it describes how we imagine Near Me will be used and what all the barriers and enablers are in order to make that happen. And this has been endorsed by the Cabinet Secretary for Health. And secondly, we're setting up a Near Me network, which is around kind of two areas. So first of all, around rapid learning and individual clinical specialties, and to understand those processes and the systems that people need to put in place for using and embedding Near Me within their teams. And then taking that learning and sharing it across the country through a network which will involve shared resources and webinars. And we've done a bit of that over the past 12 weeks and really been encouraged by the response we've had to webinars. So moving that forward into a Near Me network. And one of the key parts of that will be having data. And yesterday we launched a dashboard which enables people to see consultation numbers in different specialties across the country. And the final thing that we're just about to start next week is a Near Me public engagement and an awareness raising exercise. And the reason for this is we are really aware of the response that we get back from people in terms of those people who've used the system, and they tell us their feedback because of the pop-up survey, it comes at the end. But what we don't know about at the moment is the other people, so the wider public who haven't had a Near Me consultation. What are their views? What are the barriers for them? What do they think would be good about it? And so we're hoping that public engagement exercise will help us give a much broader opinion on Near Me from the public as a whole. And part of that is linking up with the Connecting Scotland programme, who are around looking at some of the barriers in terms of digital exclusion. And we're starting some work with them around how to enable, to start off with a GP practice to address some of those digital exclusion barriers. So lots still to do, but I hope that gives you a flavour of what's happened over the past 12 weeks and what we've done with Near Me. And I'll hand back. Thank you very much.
Claire, thank you very much. That was brilliant. And I'm sure there's going to be lots of questions. Can I encourage the audience to use the Q&A function? And at the end of the talks, we'll go through the questions, or as many as we can. And of course, the webinar will be available on the college website for some time for you to view. So next up, we have Charlotte. And now I'm not sure if Charlotte's got a dog as well that's starring in the background that Claire had, or a young toddler. Charlotte is an ST4 and a clinical lecturer in urology, and she's going to talk about her experience of setting up a training program for medical students.
So thanks very much for inviting me to join the panel today. I'm going to talk a little bit about my experiences over the past year of carrying out my master's research project in teaching video consultation skills to final year medical students. Now, a year ago, COVID wasn't really on the horizon, and video consultation was really something that was happening up in Highland, as we've heard from Claire, but certainly not at the scale that is happening today. So why did I choose this as a topic for my master's in medical education? Well, this was following a discussion with my supervisor, Professor John Duncan, who's one of the previous vice presidents of the Royal College, and he was the then interim head of school for Aberdeen Medical School, who were my employer while I'm out of programme and from my urology training. And he had been having discussions with other people in medical education in Aberdeen about potential projects, and this was something that they'd felt was going to happen at some point in the future. I think he possibly hadn't realised how much of a clairvoyant he was, because it's obviously become much bigger than was expected. So I started looking into it and thought this was really interesting, and had a quick look through the literature and really couldn't find very much in the literature specifically about education in the skills specific to video consultation. And so I decided to take this further and take it on as a project. So I opted to use a quality improvement project approach. So used the PDSA, Plan, Do, Study, Act framework, and started with my fact finding, and I had 3 stages to this. Firstly was to do a literature search and a systematised review, which found 41 papers relevant to the topics, roughly remote consultation and education, and various searches around those terms. And when I looked through these relevant papers, there really seemed to be quite a change over the past 10 years, from sort of 10 or more than 10 years ago, there being a call for a change in the curriculum to include this as something to be taught to medical students, and then to more recently some studies actually publishing evaluation of teaching programs, teaching sessions, with contents as well. These coming out of places where video consultation is used a lot more than it has traditionally been used in the UK. So, for example, Australia and Canada. Then, so the second sort of prong of my three-pronged approach was to interview some of the local consultants up here in the Highlands who've been using video consultation for a long time. One of them in diabetes and endocrine had been using it for more than 10 years. And I asked them questions about the structure of their consultations, how they choose their patients, what they thought the advantages and disadvantages of video consultation as a medium for seeing patients. But really, the main crux of this was to find out if you were going to be teaching medical students to do these consultations, what would you include? And then I used both of those to design a survey which was sent out to the then registered clinician users of NHS near me in the Highlands, which at the time was about just over 300. I'm sure it's significantly more now. And this again was questioning them on what training they'd had, what suggestions they had for the content of a teaching session to undergraduates. So just to briefly look at the results of the survey, had was it around 13% response rate, and about just under half of those were consultants, and then the second biggest group was nurse practitioners and nurse specialists. And other than the technical training that everybody who signs up to use, all the clinicians who sign up to use NHS near me were receiving at the time, nobody had training, certainly as an undergraduate, and there wasn't really much that they'd had in terms of training in video consultation skills. And really it was the focus on had they received anything as an undergraduate. It didn't really come as a surprise that nobody had. And the other really important thing to take from that survey was the suggested topics of what they would include. So these are the professionals who are using it all the time. What would they include in a teaching session? And these focused around how do you choose which patients you're going to use for video? And this is in kind of thinking in non-COVID times. I appreciate it's slightly different at the moment. Issues about confidentiality and ethics. Suggestions about having a demonstration of the practical aspects of the technical equipment, and then a lot of the content was focused on communication skills. So the importance of speaking really clearly to your patients, explaining the process of video consultation to a patient who's not used it before, being aware of body language over the video, and that's for the clinician and the patient themselves. Thinking about how you explain a management plan and check that the patient actually understands it when they're not in the room with you, and then how to end a consultation. And these results of my initial fact finding helped me to develop a set of learning outcomes on which to base my intervention. And I planned my intervention to be a single teaching session split into several bits, which would cover these learning outcomes. So 4 separate bits, and each would take on 1 or 2 of the learning outcomes. So the session itself, I managed to run a couple of times before COVID hit. This took about over 2 hours, or just over 2 hours. And first part of that was a 15-minute introduction, and we talked about the different terms that are banded around. So video consultation, remote consultation, telehealth, e-health, these kind of things. A bit about the history of the use of video consultation in the UK and the plans in the NHS long-term plan. Advantages and disadvantages of video consulting, and then some of the evidence for and against. Then the groups are split up into 3, and they went around a series of a sort of carousel of smaller groups. So first one looking at technology, then patient selection, ethical issues, and then simulation. So in the technology group, students were given the opportunity to have a bit of a play with the equipment, put themselves up against a bright window and see how that looked, linking 2 laptops in 2 different rooms and chatting to each other through them. And then they watched some example videos that we'd written a sort of example script for with the help of one of our volunteer patients. We filmed that, and I'll just show you a little clip now. So we made a good example and a bad example, and hopefully it'll be pretty obvious which one this is.
Hello, can you hear me?
Hello,
I can hear you very faintly.
Oh, hello. Thanks for waiting. It's been a bit busy, so I'm just going to get started. How are you?
I'm not bad, but I can't see you.
Oh.
It's just a black screen
Oh, well,
here.
I can see you fine. Can you hear me?
Faintly.
Okay,
yeah.
right. So, and you're happy with doing this this video thing? I think you had a leaflet through the post.
Yeah, I'll give it my best shot.
So I'm just going to have a little look at your blood test results here.
So that video, the full video is about 4 minutes long, and then there was I hope you can see that was the bad example, and then there's also a good example as well. And this could be paused to allow the students to ask questions or to suggest what they thought maybe wasn't going too well. Then the next group was patient selection and ethical issues, and we gave them a series of mini case histories and asked them to decide whether or not they thought the patients were suitable, or possibly suitable, or definitely not suitable for a video consultation. And that really gave the opportunity for discussion around some of the points about how to choose which patients are suitable for this. And again, this was pre-COVID, so things are probably slightly different just now. And a chance to look through some of the guidelines as well. And then the third of those carousels was a simulation of video consultation. So using a volunteer patient, the first time around it, the patient was in a room next door. And then the second time we said, well, actually, let's make this more realistic, and just left them in their own home. And the patient had been sent a script, and the students were asked to take a history from them and introduce the idea of video consultation and run through some of the things to expect with the patient. And then ran a second one so the students could have a go at being a patient themselves, just to see what it's like to be on the other side of a consultation. And as a result of that, we developed a checklist, which initially was sort of for the students, but actually it's now available on the TURAS website for clinicians to use, just to help if you've not run a video consultation before, things to think about when you're planning to do a video consultation, what to do beforehand, during, and then at the end of the consultation as well. And that's freely available to anybody to use. So in terms of my masters, how did I get some data from this? Well, evaluation was really key to this, and this was in two forms. Firstly, subjective, and then secondly, objective. So the subjective evaluation took a form of a survey that the students were asked to complete. They completed a small part before the teaching session, just to gauge their awareness and knowledge around video consultation and the skills related to it, and then the rest they completed afterwards. And then we ran as part of a bigger OSCE, a single OSCE station with a video consultation and so slightly adapted an OSCE question that had already been used before, but to make this as a video consultation, and added in a few pointers on the mark scheme specific to video. And students did that before and after. I won't go through all the results because it's a bit busy here, but the point of this slide is just to show. So down the left is all of the learning outcomes. This is the subjective evaluation, so the students grading their confidence and their ability to fulfill the learning outcomes before and after. So they graded themselves from 1 to 5, 1 being not at all confident, 5 being extremely confident. And if you look at the difference in the mean scores for the 40 students who came to the session, or the 34 students who filled in the feedback forms, I should say, they increase their confidence in all of those areas, and those are all significant when you do a t-test on them. In terms of the written feedback, the students, and again, this is pre-COVID, they said, and this actually surprised me, I'd wondered if students would think that this was relevant to them, because video consultation, again, isn't something that they've really been exposed to a huge amount yet. But they were already saying, this is really useful for us in the future. We can see this is going to be a big thing. They liked the session. And then some things that they suggested, maybe some more time for simulation. They wanted some more feedback from the volunteer patient. And they suggested maybe we could use video consultation to revise other clinical content as well, rather than just teaching the skills around it, but use it to teach other things. And then looking at the OSCE station results, unfortunately, when we only managed to run one OSCE before COVID hit, and then we weren't allowed to do any face-to-face OSCEs. But in terms of the video consultation specific communication skills, so this is the fourth column there, the skills that the students had before they had the teaching, they basically didn't get any of the marks, which as you'd expect. And then after they'd had that teaching, they were picking up some of these marks. Unfortunately, the numbers that we had for the post-teaching OSCE were really small because there was a big Wi-Fi failure on the day that we ran it. And so most of the students ended up having to do a face-to-face consultation with our patient, which was a bit of a blow. And I was planning to repeat that, but then COVID happened. But anyway, small results, but positive. So what's next? Well, the teaching session's been modified based on the feedback, and it's now, because of COVID, this has now been entirely adapted to be delivered online, which will start in the coming months, certainly up for the students at the University of Aberdeen. With, as Claire mentioned already, with colleagues who are on the panel, we've developed some clinical education resources, and I had a very small part to play in this, but one or two of the bits that are available on that on the TURAS website came out of this teaching, and there are the links to those, the example videos are accessible from there as well. And then my project really was a pilot, which I'm now trying to roll out, or in the process of rolling out through the UK Council for Clinical Communication. So really, since COVID hit, there's been a lot of interest from the other medical schools in the UK about wanting to teach this material to their students, and a lot of people have been in touch with me asking for my teaching materials, which I'm very happy to share. But since there isn't really much in the way of publication out there, I thought this is a good opportunity to gather a bit of data and try and get something in the literature from the UK with an evaluation. So that's hopefully going through ethics fairly soon when I finish the running form, and then we can hopefully get that rolled out for the next academic year. And then again, hoping to publish sort of that. So I've sent a paper off to the medical teacher with the pilot project. And if anybody's had their surgeon's news yet for this month, there's a little summary in there that I've written as well. And that's sort of juggling that with being 8 3/4 months pregnant and looking after a toddler and lockdown, but that's the sort of normal for everybody at the moment. So that's me. So I'd be very happy to answer any questions if you type them in the chat box at the end, and feel free to tweet to me or email me.
Thank you very much indeed, Charlotte. And please ask your questions in the Q&A box at the bottom, and we'll cover those, or as many of them as we can, at the end of the session. So next up is Idris Thomas, who's a consultant psychiatrist, and he's going to talk about tips and tricks, amongst other things, and music for mentoring and training. Over to you, Idris.
Thank you, Angus, and hopefully not too many trip-ups either. I'll just start sharing my screen. Hopefully you will be able to see the slides shortly. So thank you very much for inviting a psychiatrist to a surgical webinar. I'm not sure that that's happened all too often. Today, my colleagues have already spoken quite a lot about the need for training in this, and also how to roll it out, and the kind of practical implementations that are needed. So today I'm just going to have a quick run through really the setup. Claire spoke lots about the different kind of things to consider. I'll cover a couple of maybe clinical scenarios that you might think that you could apply. We'll have a quick chat about the consultation, which takes a lot of the points from Charlotte's training essentially, but again as an overview, and if you're wanting more details on that, we can maybe talk afterwards or look at further training. A brief run through some of the ethical considerations, and then where this might sit in training as well, and how moving forward you might find it useful. So there are lots of questions to ask with the kind of basic setup, even before you start to see a patient. And Claire's definitely covered some of those. The two I'm going to maybe highlight in this is, what is the clinical setting you're considering, and what are the anticipated disadvantages? And not just highlighting the disadvantages, but how can you overcome those? I think we come across a lot of people who say, oh, that's never going to work for us. We need to do this, and that's not possible. And actually, there are lots of ways around that. With the basic setup, things you have to think about is, where's the patient going to be? And is the patient going to be alone, supported, or supervised? So especially outside of psychiatry and in some of the more hands-on clinical practices, we have people saying, well, it's not possible to do that. I need to examine the patient. I need to look at this, and so on. But actually, with the help of allied health professions in supervised or supported clinics, you can have exams done that help individuals, and that help individuals access video consultation, and so someone like a mental health or physical health practitioner alongside the patient can do the necessary on-site examinations. And also then can further physical investigations be arranged, bloods and so on. So barriers you might have thought that's never going to work for me can be overcome. When you think about clinical applications, you can look at planned clinics, urgent assessments, at-home appointments, or collaborative care, where you're maybe linking into primary care. So all of those things can be arranged using video consultation. At home is obviously where the focus is at the moment. So as Claire was saying, this can be the clinician at home or the patient at home. And beyond COVID, there's a number of reasons why this is a really valuable way to see patients, and also for us to maybe engage with patients in this COVID era. The consultation itself has a number of points. You need to introduce yourself, you need to check the patient details and the quality of the connection. You have to explain if someone else is in the room around you, and check if anyone else is at the peripheral site, because confidentiality is a really big issue here. You have to check consent. There's some kind of mixed national guidance on this, but generally you need to check consent that isn't just implied, and you have to make sure you have up-to-date contact details for the patient. And steps that can maximize the quality of the video connection. So as you can see, I've got a relatively neutral background around me. There's hopefully no lighting glare. You can close window blinds, make sure all that works reasonably well. Fix your chair so you're not moving around too much, and make sure that the camera is at a reasonable angle so you're not staring around. And explain to the patient, if the notes are over here, why you're moving around and what's going on. And if you haven't got these kind of nifty headsets, soundproofing can be quite important. And also as a clinician, you need to be aware that the distance between you and the patient can have a direct impact on really your clinical decisions. You might feel that you're distant from the patient, so you're not as engaged, and therefore managing risk isn't quite as it would be face-to-face. Ethically, you need to consider that video consultation is a change in standard clinical practice, so there are some ethical implications we need to think about. We think about consent, and there's some tech advice on that as well. So I'm not sure if Claire might be able to signpost with some web links afterwards where there's advice relating to this. But really, you need to ensure that the patient is aware what the appointment is, and they're happy to proceed really when they've seen you face to face. And it doesn't take much time really in an appointment to say, is the connection okay? Are you happy to proceed? Software and security, I've seen some questions as they relate to maybe NHS England more than Scotland. And in Scotland, we're really lucky with the work Claire's done with NEAR-Me, and that's all been approved from a data protection perspective. But if you are looking to set up other kinds of video consultation systems, you need to be aware of software and security. Documentation is an interesting one, because if you have electronic documentation, that's easy. But if you're relying on sending tapes to secretaries and they're working away from you, or if you have to get paper notes to you, then it can become a real confusing picture. So you need to streamline documentation. You might think, why are these all ethical considerations? And the reason is that we need to have equity of service. So what we're delivering via VC as a video consultation is the same quality and standard of care that we would normally deliver face-to-face. So you need to make sure that we can communicate well, document correctly, and that communication is important for that continuity of care. So as Claire suggested earlier, that kind of, can I prescribe? Can I arrange further investigations? And so on and so forth. Can I refer to appropriate multidisciplinary teams in their vicinity? One of the things that is maybe emerging is equivalence, and potentially a divide emerging between those who have access to this technology and those who don't.
I think we've temporarily lost Dr. Thomas there. That's one of the one of the vagaries of that we've all got used to, in fact, over these media. So while we're waiting for Idris, I'm going to he might jump back on, but I'm going to ask some questions. Claire, question to you: is NHS NEAR-Me available in England? Few people have asked that question.
So yes, but by another name. So the platform that underpins NEAR-Me is called Attend Anywhere, and that platform is produced by an Australian company, and they have we procure it for the whole of NHS Scotland for health and social care. It has been procured by NHS England for specific uses, so it's more hospital based than primary care based, but that probably is okay for all of you. Just to contact your local NHS England contact, and they'll be able to tell you how to use it. Equally in Wales, it's used in Wales as well. It is known as Attend Anywhere. The reason why it's called something different in Scotland is in the early work that we did in Scotland, patients had a bit of a difficulty with the Attend Anywhere name. It was shortened to AA, and that is associated with other organisations. So it was in the co-design process. Patients picked the name, so that's the main reason why.
Thank you. Charlotte, there's questions about where folk can get hold of the checklist that you put up, that you use as part of the teaching aid. Is that readily available for people to view and see?
Yes, it should be. Claire can probably help with that as well. It's on the TURAS website. I can probably pull up a link and put it into the chat box. I think it's probably the easiest way.
Okay, we'll put that in the either in the Q&A or put it in the chat box. Can we talk a bit about consent and the clinical governance arrangements? Because again, a few questions about what other media could be used. Could WhatsApp, could Skype, could Zoom, could all these other platforms be used for consultations, Claire? So you're all over governance on this, I think.
Yeah. So there's a number of things that you need to consider. There are, first of all, the kind of the governance and system issues. So you need to think about the system security policy and also the DPIA, the data protection impact assessment, and has that been done for whatever platform you're looking at in terms of patient clinical consultations. So for the Attend Anywhere platform near me, that has all been done and is all in place. It hasn't necessarily been done for other platforms. So you do need to investigate that first, and that will be done. It could be done on an organisational level, and we've obviously done it nationally for near me. So that's the first question. And then the second question is to consider actually about the patient interface and the clinician experience. So there's a real difference between a video conferencing platform, if you like Zoom, which we're on now, which works fantastically for this kind of scenario. But actually for a patient and for a clinician, something like a waiting room function, which near me has, so a patient can enter, they can be held in a secure waiting room until the clinician is ready to connect the call. So that's beneficial to a patient. It's also beneficial for a clinician in terms of they can see the patient at the time they want, rather than the patient suddenly popping up on the screen, and knowing that the patient is there as well, rather than some types of devices you need to kind of hope that the patient's going to answer and so on. So I think look at both the patient and clinician experience and also the governance issues that are in arrangements that are in place.
Idris, you're back. We're just saying that's one of the issues with these consultations, is that there are technical mishaps.
Yes, it couldn't have timed better, unfortunately. My apologies for that.
That's right. Can I ask you, Idris, if that happened, I mean, it certainly happened to me, that if I'd unstable connection and you're halfway through a consultation, what advice do you give to peers, and what do you tell the patient?
So it's interesting, because when we were designing previously the first round of this all the way back in 2018, we were looking at contingency plans for when connections broke down, actually. So NEMI has a really good function where the patient mobile number pops up alongside their name when they complete the form correctly at the login. I always make a note of taking that down, because today the reason my software currently isn't working is I've been using my hotspot all day to do near me, because the NHS technology hasn't been up to the scratch. And so across Scotland now, I've worked in various places where it doesn't work, and having a contingency plan where you make sure you have the patient details for when something goes wrong, because it's bound to at some point. The more and more patients we see, you can just give them a telephone call then to check that everything's okay, that they've had the follow-up. And as Claire said earlier, telephone kind of sits almost before near me in this kind of scale of what we can offer. And so sometimes things have to default back to telephone when things don't work.
Yes, and certainly I've used telephone clinics for a long time, and they work very well. Particularly if you've met the patient beforehand and you've had the consultation, you may have physically examined, or in surgery there may be post-op, and actually saves them a lot of time. And it's a good old Scottish invention after all. Charlotte, where what's the feeling about medical students? Do they feel that this is the future? Have they grasped this kind of post-COVID concept that they're going to use virtual consultation as part of their normal working life?
Yeah, that's a really interesting question, which I can only really speculate the answer, because the teaching that I've been doing for my master's was all up until social distancing started, sort of at the end of March. But certainly at that point, even pre-COVID, the students were saying that this was relevant to them, which, like I said in my presentation, I thought that was really surprising, because one of my reservations about taking this on as a project to teach to medical students was that they might not think that this was particularly relevant, particularly given that even as a final year medical student, which is the group that I was teaching, even to be seeing patients in a clinic setting, even a face-to-face clinic, they're still likely to be 3-4 years away from that realistically as a medical student. But these students, all of them, it was a unanimous thing, and that was part of the survey that I gave them, was how relevant do you think this is to your future career? And they all said really relevant, and that was before COVID, so I would expect that would just be even more so now.
Claire, the few questions about different specialties, and I know that it's been used by lots of different medical specialties and allied health specialties. Particular question about pediatrics. Near me, does that work in pediatric consultation?
Yeah, pediatrics are really big users of Near Me, and I think that is partially to do with the patient group. So actually, younger people much more familiar with video technology, and so have embraced it really positively. So in fact, this afternoon I was on a call with a whole lot of pediatric specialists, just talking about exactly that and hearing their experiences and how positive some of those are. What I come back to every time I talk about Near Me is it is a tool for clinicians to decide how to use. So it's about you saying, within my practice and within the kinds of consultations I'm going to do, and within what's going to happen in this next consultation, not necessarily for all patients in this particular group, but in the consultation I know that's going to happen for this patient, will it work for that situation? So it's a tool for you, not anything more than that.
Okay, great. The number of questions about how long does it take? Is there a learning curve to pick it up? How do we fit it into job plans? Can you see fewer, or can you see more patients in a virtual clinic? Idris, what's your experience?
Yeah, thank you. I actually don't find it really, from a time perspective, more difficult to manage than a standard clinic. And actually this extends, and unfortunately with my tech failing, the end of the presentation I was going to talk about its use in training. The trainees I've had use this technology as well to do new patient assessments, to do follow-up assessments. They're allocated the same time in their clinical session for a Near Me appointment, whether it's new or follow-up, as they would for a face-to-face. And it captures it, even with giving a slight introduction at the beginning. It doesn't really drag out the appointment further than you would expect. And actually some patients, to different patients in different ways. And I think with the boundaries, you have to be careful that patients still understand it's a professional relationship and they don't start talking off on topics, because they might be a bit more used to this maybe from family interactions and things like that. But as long as you maintain your professionality and it's a professional environment, even at home appointments, they've gone very smoothly with no extra time needed.
Excellent. What about a multidisciplinary team discussion? Claire, have you got examples across Scotland where you've been with a patient and maybe a patient's relative has been able to join along with one or two consultants? Has that happened?
Yeah, absolutely. So I almost don't know where to start with this. So an example, so a patient who was some distance from the hospital avoided the journey to see their oncologist, and actually was being referred for surgery to a specialist. And so rather than having two journeys, so one to that first consultant and then the second one down to the specialist, and then another trip for the actual surgery, the first consultation was all done together with all three people, and indeed the patient's daughter who was elsewhere. So four separate people bringing them together, and all of them talked about how much better that was in terms of the care planning. So rather than it relying on a communication that happened afterwards, so a letter afterwards to say this is what was discussed with the patient and this is the plan, actually everyone got involved in that discussion, and it was clearer and easier for the patient. He was comfortable with that. Equally, some other examples where maybe a member of a community team has been brought into a consultation. So the consultant and patient have had the consultation with a community team member brought into, and they're going to take over maybe the ongoing management of the patient, so the regular input that the patient's going to have over the next few weeks and months. And having them involved in that initial consultation meant that they were much more confident about what was expected to happen. So for sure, I mean, loads of examples. I'll just give you those two because I think otherwise I'll be here all night.
Fantastic. Yeah, Idris.
Just to add to what Claire was saying then, for the trainees in the audience as well, this can be a really useful tool to bring in your clinical supervisor to do things like KEXs and CBDs, where actually you engage with or even just general day-to-day clinical supervision, where you have an appointment with the patient, and then you maybe want to have your senior join in towards the end or be present throughout. So having that ability to have clinicians join is really invaluable for trainees too.
Where do we stand on specialties such as ear, nose, and throat, where really the consultation is all about, examining as part of the clinical process? Have you got examples where that has happened, or is it really not appropriate for some patients?
I've seen some small use in ENT. I agree that there's an awful lot that actually it is going to require a physical examination, and that's why I always say, it's a tool for you to decide how to use. Having said that, there are some examples of people using quite advanced technology with very specialist cameras. So in remote sites where the video camera itself can provide additional information, but that isn't to people in their own homes, so it's less appropriate at the moment in terms of COVID, but I think there's more work to do there in the future to understand some of that specialist video cameras some more.
Yeah. Certainly, we've been piloting using a high definition camera for looking at diabetic feet, for example. So those cameras have been deployed in patients' homes, and the specialist has got a close-up look at the skin, which is very valuable information. Yes, you're going to come in, Claire.
If I can just come back in on cameras, because there's a top tip that is useful for people to know. So most patients consult with a smartphone, and there's a big difference between the selfie camera, so the one that they're most likely to use when on a video call, and the rear-facing camera. So if you're looking at something like skin and you want a better image of the skin, if you say to the patient they can change their camera setting in the call and switch to the rear-facing camera, then you're going to get a much better image. So of a foot, for example, than you would on the selfie camera.
Thank you. Top tips. What do we think about, Charlotte, about recording consultations? There's a question that's often asked: are you recording this? Can I record this from a patient point of view? Do you know what are the issues around that?
Yeah, well, I am fairly certain, the others will keep me right, but that Near Me doesn't allow you to record consultations. And this is something that we talk about with the students in the sort of ethics part of the teaching session. And it's something that we would recommend that clinicians would say in their introductory spiel to a patient who hasn't used it before, just to let you know this is not being recorded, and that's the technology doesn't allow it for exactly that reason, for confidentiality. So I suppose you might think, well, it'd be a useful way of having a sort of documentation of it, but I think there's too many sort of potential issues with data storage, and it would also be a huge amount of data again as well, I guess.
And what about, Idris, about chaperones? A few questions about chaperones and whether it's appropriate to have someone else in the room And if you're asking intimate questions, do you need, as a clinician, do you need a chaperone to make sure that everything is kept safe? Where do we stand on that?
I think you'd have to be on a case-by-case decision. Essentially, you probably couldn't have a blanket rule on whether people needed a chaperone for a certain clinic unless it was already established. So maybe potentially in gynecology, where it's already advisable to have a chaperone for certain things, you would maybe say, right, well, we have one there. We're not going to change that, and we're going to continue with that clinical practice. Certainly, I can speak more in mental health, we're used to not having chaperones and still asking quite delicate and intimate questions. So it's not something that by default you would need. And you can always have a chaperone join as a third person from a separate location if you felt that was needed. So it still doesn't have to necessarily change the dynamic. If you were working from home and the other person was in work and the patient was at home, you could have that three-way chaperoning consultation if it was felt it was needed. The recording is also interesting because patients can have the right to record their consultations, but really that should be discussed with the clinician in advance with regards to audio recording. So I think if you were highlighting to the patient, we're not recording this, you'd expect them maybe to say, and I hope that's not the case, or you could even add that in if you were worried about specific patients and that as a problem.
Yeah, certainly I offer that with my inflammatory bowel disease patients, where often you're having quite a long consultation, and I ask the patients if they want to record the consultation on their mobile phone so they can play it back later. What about if we want to do a procedure, Claire? So we want to get some bloods taken, or we want to get a blood pressure done, or other intervention. How can we use the system for that?
I think pre-COVID, we often set up remote clinic locations where a patient could come into, and a member of staff would support them with that. So a healthcare assistant, for example, could take bloods and so on. I think where we are now currently is a lot of those remote hubs have been closed because of the infection control risks that are within them. So we are looking at linking much more with local services and working out how to do that. I think we've probably got to relook at all of our models and work out what best to do going forward.
Charlotte.
Just one thing I remembered on the previous point about intimate examinations, the digital health, NHS Digital, I think it is, have just released some guidance specifically on intimate examination via video consultation in the last couple of weeks, which I haven't had a chance to look at yet, but anybody who's interested could look that up.
Okay, great. There's a particular question about patient feedback, and I know that you've been working with colleagues in Oxford University, Claire, about feedback from clinicians and patients, and that's been published fairly recently in the British Medical Journal. Can you just elucidate on some of the findings?
Yeah, so we've looked at a number of different areas for gathering information. You're absolutely right that University of Oxford evaluated the first part of our programme, which was all pre-COVID, and I'm absolutely delighted to say that we have now extended that contract with them so that they are looking at what's happened over the past 12 weeks. And clearly part of that is understanding fully both patient and clinician feedback. So from the early stages, we tend to find that now with this particular platform, there is a much higher rate of acceptance in terms of use. And I think that's because of that difference between using a video conferencing solution and actually a program that's designed for video consultations. So that's been really useful. Obviously, we've got our own feedback survey from patients where they are clearly identifying that they're happy to use the system. I think it's important to note that we still have some technical difficulties, so there is still a percentage of patients who struggle with technology, and part of what we're doing next is really trying to understand that much more. So our own kind of consultation that's starting next week with the public in general, as opposed to with users of the system, will help us understand that, and we're linking that in with Oxford at the University of Oxford team as well, in terms of kind of the questions and things that they want to explore. So I think we'll have a lot more knowledge in probably a month or two's time, But right now, I would say that acceptability is I mean, higher than I would ever have imagined, and mostly patient feedback is really positive.
Great. Idris, the question about breaking bad news on these kind of media, and it's obviously not ideal. We would want to do that face to face, but if we can't do that because of the pandemic, are you aware of any instances where bad news? Claire's put her hand up.
Yeah, and actually, I think maybe this is one of those where it's clinician preference, maybe more than actual patient reality. So depending on your geography, your support networks, who's around you, and breaking bad news comes across in a variety of settings, not just kind of terminal news, but all kinds of potential bad news. If you have to travel on your own to see someone hours away and be told something and then have to return, that's sometimes patients might think much worse than actually I'm in my own home with someone I love next to me and we can have that discussion and I am relaxed and I'm not anxious and I don't have to drive, I don't have to put myself at risk. So actually, I think this might be one of clinician reluctance more than patient kind of preference.
Very good point. Claire, you wanted to come in.
Idris has put it beautifully. That was very much what I was going to say. And our experience with clinicians who do routinely break bad news using video say that the important thing is to prepare the patient in advance. So to have a discussion with the patient to say, it is possible that we will be talking about bad news within the next consultation. Where would you like to have that consultation? Would you prefer to come into a clinic and have it face to face? Would you feel more comfortable having that in your own home? And then all the standard things that people ask about, having someone with you and so on. So actually it's more about that and giving the patient the choice, and that has revealed that many more patients have actually opted to have it at home, although there is a percentage of people who would like to have it in close to home but not in the home because they then associate the bad news with the room that they were in, and that can be difficult for some people in their own home. So it's all about that patient choice.
Fascinating. Now, the Royal College of Surgeons of Edinburgh are really keen on sustainability. So I want to know how many carbon miles NHS Near Me in Scotland has saved, Claire.
I am really sad to say I don't know at the moment, but I know about your use of your service and the figures that you've given are fantastic, and it is absolutely one of the things that we're going to pick up next. I have to say, all of us have been just blown away by the uptake of Near Me over the past 12 weeks. So some of that routine things that we might have collected has slightly fallen away. But yeah, absolutely. Carbon miles are hugely important and a really significant amount of interest in that going forward.
Yeah, I mean, we have done a little bit work around colorectal, which is my specialty. And out of about 50 patients, they saved about 120 minutes traveling time on average. And it's thousands and thousands of miles not traveled with a very high satisfaction rate. So I'm a complete convert. Yes, lots of hands going up here.
So I'm just really simply going to say, if you times that by the 150,000 people who've had a consultation by Near Me since we started, then you've got a scale of what the carbon saving could be.
That's why the sky is always blue in Highland. Charlotte, you were going to say something.
I was just going to say that having done some of the data crunching for your patients, Angus, I pity the person who's going to have to do the 160,000 calculations in Google Maps that I did for 50. That's not long enough.
So predictions, we've got a minute left, and thank you everyone for their presentations this evening, and thanks from the college, and thanks for everyone who's attended. We've had up to 200 participants this evening, which is brilliant, and thanks for your questions. The webinar will be available on the website for people to view later on. Claire, do you think that this is here to stay? Do you think this is a flash in the pan, a pandemic flash in the pan, or is this going to be here forever?
I think it's here to stay for two reasons. One, because I think patients want it, and I think we've understood that. Not every patient, but there's a real percentage of patients for whom this is about enabling attendance, and that's important. And secondly, for the environmental reasons that you've just mentioned, we've got to do things differently if we're going to sustain the planet. So yeah, I think it's here to stay.
Charlotte, Idris, here forever?
Yep, definitely.
Yeah, and actually growing, I would say, rather than contracting. I think we barely scratched the surface with home appointments and what we can achieve. And just thinking of all the patients I've seen today, their preference maybe next time is to have this rather than even coming in when COVID restrictions are lifted. So I think when we think about patient preference, this is high on the list of what they'd actually want.
Brilliant. Well, I'm going to bring it bring the session to a close just now. Just a little bit of advertising that the Viking Surgeons are an association who have surgeons in lots of remote and rural locations. And we were going to have a physical meeting here in the Highlands in the autumn, but instead, because of the pandemic, we're having 3 virtual webinars on the 15th, 16th, and 17th of September. And then we'll be having a monthly webinar thereafter on lots of topics, from trauma in rural locations to how do we get involved in the specialty, to what's happening internationally across the world. So put those dates in the diary. Thank you once again for the panelists and for all you who are attending, and I wish you good night. Thank you.